Next, I have the pleasure of introducing Dr. Carl Lavie. So Dr. Lavie attended the med school at LSU School of Medicine, New Orleans. He did his internal medicine training at Ochsner and then his cardiology fellowship at the Mayo Clinic. He's currently professor of medicine and the medical director of cardiac rehab and prevention and the director of the exercise laboratories at the John Ochsner Heart and Vascular Institute and the Ochsner Clinical School, the University of Queensland School of Medicine in New Orleans. He's authored over 1,600 medical publications, multiple textbooks, and serves on more than 40 editorial boards, including the Journal of the American College of Cardiology, the American Journal of Cardiology, and he's also the associate editor and cardiovascular section editor of the Mayo Clinic Proceedings, as well as the editor-in-chief of Progress in Cardiovascular Diseases, and the author of the book, The Obesity Paradox, that some of you may have heard of. So without further ado, Dr. Lavie.
Thank you. Thank you very much, and it's a privilege to be here. Thanks, Mohamed and your colleagues, and Sabina particularly for arranging all of this. And I get to talk on one of my favorite topics, that is on physical activity, exercise, and cardiorespiratory fitness. Here's my disclosures. I was a consultant in the past on a health app for personalized activity intelligence. I've not been doing this for the past year. And he mentioned the Obesity Paradox book, but that's a decade old now, so it's probably not much of a paradox. I was very pleased that the editor-in-chief of JACC, Valentin Fuster, probably the most famous cardiologist in the world, asked me to senior author the Promoting Physical Activity and Exercise paper in his JACC Health Promotion Series several years ago, which was very exciting. I was mentioning that I'm editor-in-chief of Progress in Cardiovascular Diseases, and I've had a couple of issues over the past decade on physical activity. This is one that I teamed with a very famous exercise person, Ulrich Wisloff, in Trondheim, Norway, and we had a very excellent issue, and we've had one other since then. This is an old study. It had got headlines when it came out. It was from Wen and colleagues in Lancet over a decade ago of 450,000 people in Taiwan. Now, what the headlines were when it came out was that all you had to do was 10 minutes of physical activity to get mortality reduction. So people like that, and that's what they really emphasize in the press. And I'm going to get back to this study toward the end. But if you notice the physical activity with age, that up to about age 60, the mortality was low enough that it didn't really matter that much whether you were physically active or not physically active. But after the age of 60, the lines really start diverging, and there becomes a big difference in survival between those who are more physically active and less physically active. Now, one of the things that physical activity does is it promotes cardiorespiratory fitness. And some people are fit without being very physically active because there is a genetic component of fitness. But it probably is mostly due to physical activity. And this is a paper by Kokonos and colleagues in Circulation 15 years ago that showed the highest, but typically we have really good ways to measure fitness, cardiopulmonary stress testing, but most people measure it on the treadmill test by the speed and the incline of the treadmill, and they get an estimated METs. And this was shown years ago that the higher your METs were, the better was your survival. And in fact, many years ago it was said that once you got to about 10 METs, you had maximized your survival benefit. And I think we now know that getting higher and higher, 12, 15, 18, 20, is even better than 10. But of course, the slope is not nearly as high as going from 5 METs to 7 METs and 7 METs to 10 METs. And this is a meta-analysis that's been very heavily cited by Kodama, in JAMA in 2009, of 33 studies, over 100,000 people, that made the point years ago. The meta-analysis showed that for about every 1 MET change in exercise capacity or cardiorespiratory fitness, mortality and CVD, CHD events were affected by about 13 and 15% respectively. And one of my friends, Jari Luukkonen from Finland, just did an update on this of 37 studies and 2.3 million participants that basically showed for about every 1 med change, that's now about 11% reduction in mortality. I was fortunate to write the editorial on this paper in the Mayo Clinic Proceedings, making the case that we probably should be including cardiorespiratory fitness as really a vital sign in our practice. Peter Kokonos, I showed his circulation paper earlier. He just had a paper in JACC evaluating cardiorespiratory fitness on the treadmill in the big VA cohort of 750,000 who were followed for about over a decade, about 15 years, and assessed their mortality and showed that cardiorespiratory fitness affected mortality across the spectrum of age, the spectrum of race, very much similar overall of results in Caucasians, African American, Hispanics, and in both males and females. Dr. Galati and I just actually had a paper in the Mayo Clinic Proceedings together showing that there's actually disparities in physical activity in our females, and of course it's often related to diversity as well, but certainly it looks like that many of the females are not getting the physical activity, which is probably going to affect their cardiorespiratory fitness levels. But this paper showed that in females, cardiorespiratory fitness, as it was in males, was equally as good for predicting survival and was better than most of our standard risk factors. In fact, this paper made the case that if you had a significant risk factor like lipids or hypertension, even smoking, or dyslipidemia, if you were fit, you had a better prognosis than those without the risk factor who were unfit. I fortunately was asked to write the editorial for this paper and really made the case in this editorial that probably the group that now practice that has the most to gain in the United States is the African American population, because the African American population have been shown to have lower levels of fitness and more obesity, and also they seem to be getting even less of an increase in their fitness levels with routine exercise training programs. They probably need more high-intensity exercise training. And recently I teamed with Peter Kokonos in a paper that just came out in JACC very recently of 93,000 people in the VA cohort that actually looked at changes in their fitness level over time and its effect. The fitness level that was measured approximately 6 or 7 years different in time, and assessed the effect of changes in the fitness on survival, and showed that, of course, if you were more fit to begin with, you had much better survival. But at any given level of fitness, if you can actually improve it, you improve your survival, and vice versa. But at any given level of fitness, if you significantly worsen your fitness over time, you increase your mortality rate. So a paper that really shows that we can impact the survival, cardiovascular mortality, and all-cause mortality by improving fitness over time. Now, the benefits of physical activity, exercise, fitness have been noted for centuries. Cicero said exercise and temperance can preserve something about strength in old age. Socrates said, and it's not bodily habits spoiled by rest and illness, but preserved for a long time by motion and exercise. The Earl of Derby said, those who think we have not time for bodily exercise will sooner or later have to find time for illness. And the famous clinician, Paul Dudley White, said, healthy exercise is valuable not only for the maintenance of good physiologic functions of the body, but also mental clarity and feelings of good health. So if this is all true, then why do many of our patients think that before beginning an exercise program, they need to see their physician to get the okay? It seems like we should be seeing the physician to get the okay to be living a sedentary lifestyle that's been going to doom the person for unhealthy activities. Now, years ago, The Lancet, probably we're in the United States, so we think the New England Journal is the top journal in the world, and JAMA's right up there, but many people think The Lancet is the top journal in the world. A decade ago, they had a whole issue the Lancet Physical Activity series. And one of the papers by Min Lee showed that they estimated statistically that about 6 to 10% of major non-communicable diseases worldwide was attributable to physical inactivity. 6% for coronary disease, 7% for type 2 diabetes, 10% for breast cancer and colon cancer, 9% for premature mortality. And they concluded from analyzing this data, and this is over a decade ago, that 5.3 million deaths worldwide based on the 2008 death rate could statistically be avoided by eliminating inactivity. If physical inactivity was decreased by 25%, could reduce by 1.3 million deaths per year worldwide. And if you just reduced it by 10%, it would be over 500,000 deaths per year worldwide, could potentially be avoided, again, at least statistically. It was mentioned earlier that I'm the author of the book, The Obesity Paradox, and we're going to discuss some ways that physical activity and fitness play a very significant role in this. I was very pleased as well that Valentine Fuster several years ago asked me to lead the Healthy Weight and Obesity Prevention article that's been very successful in this JACC promotion series. But first of all, I'd like to talk about what's the fundamental cause of obesity. Now, Dr. Kopecky kind of alluded to, he wasn't specifically talking about obesity, but all the dietary factors. Certainly a lot of people blame obesity on fast foods like McDonald's, Burger King, Taco Bell, blame it particularly on the sugary beverages, Coca-Cola, Pepsi-Cola, Dr. Pepper, et cetera, and the junk foods. And this is certainly involved, no question. But my colleagues and I really believe that the fundamental cause of the massive increase in obesity over the last 5 decades is because of decreasing physical activity and energy expenditure. This is a pretty big paper that we published a decade ago where we basically measured 5-decade trends, 45-year trends in women's use of time and household management energy expenditure. So what we were basically measuring is housework in women over 5 decades. And this paper got a lot of publicity. It wasn't all good publicity. I'll just give you an example. There was a picture of me in a major U.S. newspaper that had a caption under it and said, "Women are getting fat because they're not doing enough housework." You can imagine how that went over at the home front. My daughter, who was a medical student at LSU, came home and told me that my sister, who was a social worker, was not very happy about my paper. We were on Jay Leno's talk show, one of his last monologues. We were on Fox News 3 times in one night. Y'all probably don't watch a lot of Fox News here, but it's on every night in Louisiana. Maybe not as much anymore since Tucker Carlson just got fired. But basically, we showed what you would predict. We just measured it, that over 5 decades, there were massive declines in energy expenditure. On the average of about 1,800 calories per week, which if you use the formula that about 100 calories are burned for every mile traveled by foot, and that's not a perfect formula, but that's the one we typically use, that would suggest that the average woman would have to walk 18 more, or jog 18 more miles per week currently to make up for the calories not being burned that was burned 5 decades ago doing household chores. Now, one of the reporters asked me also in an interview, did we study housework in men? And I said, are you kidding me? Men don't do housework. It's dangerous. It causes blindness. It causes low T. She didn't think that answer was too funny, actually. And actually, a lot of men do housework now, but probably 5 decades ago, there wasn't a lot of men doing housework. But we did measure occupational energy expenditure in men and women, as you'd expect. It massively declined over 5 decades. And when we plugged this data in to the increasing in the obesity prevalence, it markedly increased the prevalence of obesity and almost totally tracked with the decline in physical activity. More recently, we also assessed this in mothers with young children, and we showed, as you'd expect, activity time decreased, sedentary time massively increased over 5 decades. This is in women who had children over the age of 5, and the results are even more pronounced in mothers with children under the age of 5. But basically, in these young mothers, it's about 15 to 1,700 calories per week difference now than in the past. And so this plays a role not only in obesity in the young women, but it also, the physical activity is down. This is one of the major contributors to cardiorespiratory fitness, so it's affecting their fitness level. And there's evidence that the hand that rocks the cradle rules the health of the next population. We actually just published something that came online today in Metabolites that suggested that there's a metabolic inheritance passed on by women to their fetuses. So even the activity and weight and diet of the woman might play a role in the subsequent health and activity levels and obesity in their offspring. So how does physical activity, exercise, and fitness protect individuals from cardiovascular disease? The mechanisms are numerous. It may have to do with improving increasing the parasympathetic tone, decreasing sympathetic tone, reducing blood pressure, improving endothelial function, improving platelets, reducing blood viscosity, improving mitochondrial density, improving sleep, reducing systemic inflammation, increasing insulin sensitivity, and having beneficial effects on the lean mass, improving capillary density, reducing visceral adipose tissue. Certainly it improves many of our risk factors that are known to be part of atherosclerosis. But I think one of the things that's been neglected in medicine, and particularly in cardiovascular disease, is the effect that physical activity and exercise has on mood and psychosocial stress. We believe that stress is a significant risk factor for cardiac events, and it affects the recovery of patients following cardiac events. And Cicero noted centuries ago, it is exercise alone that supports the spirit and keeps the mind in vigor. Several years ago, I pulled together our data from our cardiac rehabilitation programs at Ochsner in New Orleans and joined with James Blumenthal from Duke. And we published this review paper in the Canadian Journal of Cardiology, going over all the effects that exercise training has on psychosocial stress and its potential on mortality. This is a paper in Archives Internal Medicine 15 years ago. That's now called JAMA Internal Medicine. And we showed then that our younger cardiac patients in cardiac rehab, these are after following major cardiac events, the younger patients, and we defined younger in this paper as under age 55, and defined older as older than age 70. We showed that all of the groups had a lot of psychological stress, but the younger patients actually had a little bit more than the older patients. It was pretty close for depression, but the younger patients had way higher levels of anxiety and way higher levels of hostility. Hostility is a way to phrase unexpressed anger. But following the cardiac rehabilitation and exercise training program, we saw dramatic improvements in anxiety. It fell by 40% in the older patients, but it fell by over 70% in the younger patients who had much higher levels of anxiety to begin with. Hostility fell by about 60% in both younger and older, but probably more important in the younger patients who had a much higher prevalence. And depression, which probably is the thing that correlates most with cardiac disease. We've published a paper in American Journal of Medicine a few years ago that showed that anxiety and hostility actually add to the burden of depression, but probably 80 to 90% of the impact on cardiovascular diseases coming from depression. We see that following cardiac rehabilitation, we get about a 70% reduction in the older patients and almost a 90% reduction in the prevalence of depression in our younger patients. Now, this is very important because we showed years ago in this paper in the American Journal of Medicine that those who were depressed following a cardiac event, they had a mortality rate of 4 to 5 times higher compared to those who didn't meet the criteria for depression. And when we assessed the controlled depressed, and we defined the controlled depressed as those who had their baseline studies for depression but didn't attend cardiac rehabilitation, versus the active depressed, meaning those who were depressed who attended the cardiac rehabilitation program. Now this is, of course, is not randomized, because you can't do a randomized study like that because cardiac rehabilitation is a quality metric. You can't tell a group that they can't do cardiac rehab when it's been shown to be beneficial. But so we basically assessed those who were candidates for rehab, but who decided not to come, but who had the baseline testing. And we showed in this paper that those who had depression and attended the cardiac rehabilitation program had over a 3 times lower mortality than those who did not. Now, cardiac rehab is as most of you know, is I think most people, when they think about it, they think about the exercise. They think about people running on the treadmill, doing the exercise bike, doing the elliptical machine. And that's certainly probably a very major part of cardiac rehab. But cardiac rehab is more than that. It also has a lot of tender loving care. They get a lot of emotional support. They get a lot of lectures. They get group therapy, kind of like psychologists and psychiatrists do. Have people in the same boat in a group, and it has benefits in bonding. So we tried to determine, since everybody got all parts of the cardiac rehab, we tried to determine what was the part that contributed to the reduction in depression and the reduction in mortality in this paper. And we showed that if we used our exercise capacity, and we actually did our exercise capacity not just by estimating the METs, but by formally measuring the peak VO2 by gas exchange. And generally with cardiac rehab, you get about a 35% improvement in their estimated METs and about a 15% improvement in their peak VO2. But we showed that those who didn't improve their VO2, they actually continued with very high prevalence of depression and high mortality. Whereas those who got just a little bit improvement in their peak VO2, we define that as between 0% and 10%, or got a whole lot of improvement in their exercise capacity, we define that as greater than 10%. They both got big reductions in their depression prevalence and big mortality reduction. We suggested at this time that you just need to improve your exercise capacity a little bit to markedly improve psychological stress and reduce mortality. We've subsequently shown that the more and more that you improve, you get even better. This is a paper we published in the European Heart Journal a few years ago of 1,171 patients following our cardiac rehab program who were followed for 7 years. In this paper, we showed, unfortunately, that in our cardiac rehab program, 23% did not improve their peak VO2. And when we were doing this paper, we actually found that Patrick Savage and Phil Ades had a paper in the Journal of Cardiac Rehabilitation almost a decade earlier that showed exactly the same percentage, 23% didn't improve their peak VO2. Their paper was only about 100 patients, and ours was 1,171, so theirs wasn't powered to look at mortality, didn't have the long-term follow-up. But we showed in this paper that the group who got the most improvement in their peak VO2 had the lowest mortality. Those who got no improvement had the highest mortality. And if you had an intermediate response, you had an intermediate mortality over the next 7 years. Now, we didn't include this in the paper. We have an abstract on this, but we actually, because we were measuring peak VO2, we could also get the estimated METs too. We showed that those who had both improvements in their peak VO2 and their estimated METs had the best survival. Those who didn't improve either had the worst survival, and if you had one of the two, and the reason why I think this is actually important practically is that most people are not getting cardiopulmonary stress tests. Most people are estimating the exercise capacity like everyone is doing every day in treadmill tests by giving an estimated METs. So you can get pretty good impact with just estimating the exercise capacity. And a later paper in the European Heart Journal assessed over 850 patients in cardiac rehab and showed basically in this paper that the most important thing was what your peak VO2 was following the cardiac rehabilitation program. So no matter where you started from, if you got your peak VO2, particularly if you got it at least over 17.6 cc's of oxygen per kilogram per minute, you had overall a quite good survival. Now, it's not just about fitness, but we're really concerned about low fitness. I mean, we would like to get everyone from the lowest level of fitness up to the highest level of fitness. But the biggest bang for the buck is just getting people out the lowest level, getting them into the next lowest level or the mid-level. And this produces big improvements in prognosis, reductions in cardiovascular and all-cause mortality. And generally, this can be accomplished by doing 150 minutes per week of moderate and/or vigorous physical activity. You're not going to necessarily make everybody super athletes by doing that amount of exercise, but most people, if they did that amount of exercise, would get themselves out of the lowest level of fitness into at least the next lowest level or the mid-level of fitness with the biggest improvements in exercise capacity. Now, we've published several papers on something called the personalized activity intelligence. I showed this as a disclosure earlier because I was a consultant on this. But this was made in Trondheim, Norway, and they first showed this in their Hunt study. We later used this in the Aerobics Center longitudinal study in the United States. And this is a paper we just published in the Mayo Clinic Proceedings where we showed this in basically 500,000 Chinese followed for an average of 8 years. Basically, I'm not going to go into the details about this, but you get more points by exercise that raises your heart rate more. So if you do just light exercise, your heart rate doesn't go up more and you're just getting a little bit of points. But if you really raise your heart rate, and obviously you're going to really raise your heart rate if you're doing some high intensity exercise training. But again, this has been shown now in several populations to be associated with mortality. I've also teamed with the group in Copenhagen with a couple of papers. This is 1 year ago in the Mayo Clinic Proceedings of about 8,500 from Copenhagen who were followed on average for 25 years. And it showed that almost all forms of leisure time physical activity improved life expectancy. But interestingly, there was different effects of different physical activities. And it looked like on this slide that the physical activity that you do in groups or you don't do solo might be having a better, at least association with prolonging life more than with things just like jogging, swimming, and cycling. And it may have something to do with maybe some sports activity doesn't just involve aerobic fitness, but involves coordination and skill and hand-eye coordination, and this may be actually contributing as well. Now, I mentioned earlier the obesity paradox. And this is a paper that I had in my very first issue of my journal, Progress in Cardiovascular Disease in 2014 by Von Berry. He did a meta-analysis of evaluating 10 studies that were prospective and objectively measured the fitness on the treadmill and BMI and jointly assessed their impact on all-cause mortality. And generally being fit was defined as not being super fit, but just not falling in the bottom quartile. Or a couple of the papers, it was in the bottom quintile or the bottom tertile. But basically showed that compared with the normal weight fit, again, normal weight who didn't fall in the bottom level, the unfit, those falling in the bottom level of fitness, had basically twice the all-cause mortality, regardless of their BMI. And the overweight fit and the obese fit had similar survival as did the normal weight fit. So based on this, he concluded that fitness was more important than adiposity for long-term survival. Now, we applied this to our cardiac patients, the patients that we see in the office every day. So this is a paper in the Proceedings a decade ago where we used the Aerobics Center longitudinal study in 10,000 coronary patients who were followed on average for over a decade, all had their fitness assessed on the treadmill, and we defined the unfit as those falling in the bottom tertile. And we measured their BMI, we measured their waist circumference, we measured their percent body fat, and showed in this paper over a follow-up of about 15 years, basically those who fell in the high fitness category, again, not super fit, just not falling in the bottom tertile, they had a pretty good survival regardless of their BMI, regardless of their waist circumference, regarding of their percent body fat. Whereas the unfit, those falling in the bottom tertile, had much higher mortality, but in that group, being a little bit heavier, had a less mortality, meaning having a little bit higher BMI, a little bit higher waist circumference, a little bit higher percent body fat, had lower mortality than did the unfit, who were basically thinner. That's kind of what I think is the nut of the obesity paradox. And we showed, again, the previous slide was all-cause mortality. This is the data with cardiovascular mortality, showing almost exactly the same trends. Several years ago, Ross Arena from University of Illinois, Chicago, allowed me to use his cardiopulmonary stress testing data bank of 2,066 heart failure patients with all low ejection fraction, less than 40%, average of 30%. And they all had cardiopulmonary stress tests to evaluate their fitness. And we assessed their mortality over the next 3 years. And we basically showed that those who were relatively fit, and we defined relatively fit as having a peak VO2 of greater than 14 cc's of oxygen per kilogram per minute. Any of you who've ever worked with cardiopulmonary stress testing or fitness data know that 14 is no great level of fitness. But that's the kind of the number that Donna Mancini published on over 3 decades ago. And this was heavily used 3 decades ago to get patients on the transplant list. Now, it's still used to assess prognosis of heart failure patients, but it's really not used to assess the transplant, because right now, the only patients that are getting transplant are those who basically can't get out the hospital, who are really bad off, who are usually on LVADs and things like that. So usually it's not based on cardiopulmonary stress testing. But basically in this paper, we showed that those who are relatively fit, peak VO2 over 14, had a quite good survival regardless of their BMI. Whereas if you were unfit, peak VO2 under 14, you had a much higher mortality, and then there was an obesity paradox, meaning in the unfit systolic heart failure patients, those who had obese had a little bit better survival than the overweight, and the worst survival was in the normal weight. We had already excluded the underweight because we knew from many studies that the underweight always, for almost every disease, have a higher mortality. Now, I should say that this is mostly a mild obesity study because we had very few people with BMIs over 35, and we actually had none over 40 because it was a cardiopulmonary stress testing study. But it certainly does suggest that an obesity paradox in the unfit patients with systolic heart failure. I laid a team with the group from Norway again, from their Hunt study, and assessed 6,500 coronary patients followed for over a decade, I think for average of 13 years. And we assessed their combined effects of physical activity and BMI on mortality. And this study also showed a obesity paradox. Those who were obese had a better survival. But that was only true in those with low physical activity. If you met your physical activity requirements, over 150 minutes per week on average of physical activity, you had a quite good survival, and it didn't matter what your BMI was. But if you had a low physical activity, you had a much higher mortality, and among those who were physically inactive, there was an obesity paradox. And subsequently in JACC, we assessed 3,500 patients with coronary disease, followed on average for 15 years from Norway in the Hunt study, and assessed the changes in physical activity and the changes in BMI over time. And the changes in physical activity were much more important than the changes in BMI. In fact, there was no group in this study where reductions in BMI were associated with better survival. In fact, those who were in the normal weight who gained BMI had a lower mortality, and those who were in the normal weight who lost BMI had a higher mortality. But physical activity was much more important, statistically at least, and those who maintained or increased their physical activity over time had significant reductions in their mortality, much lower than those in the other groups. So I think all of these studies that I just went over make the point that physical activity and fitness markedly alter the relationship between adiposity and fat and subsequent prognosis in our patients with cardiovascular disease, at least for coronary heart disease and systolic heart failure. Now, you remember I started with this paper earlier from the Wen paper in the 2011 Lancet, 450,000 from Taiwan, followed for 7 years. And again, the paper really made the point that if you just got 10 minutes of exercise, 15 minutes of exercise, you improve your survival. So that's what got the headlines. But it also made the point that the more and more moderate physical activity you did, the better was your survival, up to about 60 minutes a day where the line starts leveling off. But with vigorous physical activity, which they defined as 7 to 8 METs, which is not super vigorous. This is like, riding a bike or going on a slow jog. It's not like super high levels of physical activity, but it's a decent level of physical activity. It looks like the line is starting to level off after just about 30 minutes. And again, doing more and more does not seem to be producing additional benefits. So we did a big running study in JACC a decade ago of 55,000 people from the Aerobic Center longitudinal study. And we analyzed the data in 13,000 runners compared to 42,000 non-runners with a follow-up of about 15 years for cardiovascular and all-cause mortality. Not a big surprise that we showed that the runners had a 30% lower mortality during the next 15 years, and they had about a 45% lower cardiovascular mortality. Now, this is not a big surprise. I think many people would think running is going to have some benefits on the health, and some people would say it may be selection bias. It might be those who are able to run are healthier than those who are not able to run, so maybe it's just an association. But clearly, it looks like the runners are having lower mortality and cardiovascular mortality. But then when we looked at the dose of running, we looked at those, we divided the 13,000 runners into quintiles. And again, the cells start getting smaller if you just do 13,000 divided by 5. But in the lowest quintile, those running less than 6 miles per week, those running only 1 to 2 times per week, running less than 52 minutes per week, appeared to get the same cardiovascular and all-cause mortality benefit as those running at higher doses. And in fact, the highest dose runners appeared to have a trend for worsened cardiovascular mortality and mortality that was not statistically significant. So we subsequently took that high group and did a research letter in the Mayo Clinic Proceedings, and we took those in the top quintile, so the top 20%, and divided that group into tertiles, so we got basically the very top 8% of the runners. Those who are running well over almost 7 times a week, running 33 miles per week on average, running almost every day, they appeared to lose the benefit. Not worse than non-runners, but worse than those who were doing less running. Now, we didn't try to make too much over this because the confidence intervals are not nearly as good. But it certainly suggests, I think, that more is not necessarily better. And it might even raise the idea that more could even be worse. And this is a paper that Paul Thompson and Paul Williams published in the Proceedings that I was fortunate to write the editorial on several years ago, of about over 2,000 MI survivors, and they assessed their physical activity and their mortality over the next 10 years, and showed that those who were more physically active after an MI had much lower mortality. Went down as you did more and more physical activity up to a point, up to about 7.2 med hours per day walked or run, which is the equivalent of about 50 miles per week of walking or 30 miles per week of running. And at that point, they appeared to lose the benefit. Again, not worse than non-exercises, but less than those who are doing less physical activity. Now, I'm not trying to make the point that right at that 30 mile per week running point, right at that 50 mile per week walking, you're going to all of a sudden go from living to dying. But I think it does, again, make the point that more and more is not necessarily better. And, in fact, more could be worse. And again, it may be a difference between exercising for health versus exercising for longevity and for peak performance. Because if you're an athlete, you have to do more and more. If you're going to win the race, you got to do more and more. You got to do interval training. You got to. But if you're doing the exercise for just health, for cardiovascular mortality and all-cause mortality, it certainly does look like more may not be better. And in fact, we do know that there's some potential harms for extreme levels of exercise. James O'Keefe and I published this paper that got a lot of publicity years ago about the potential adverse effects from excessive endurance exercise. We basically define this as marathons, ultra marathons, triathlons, and showing that the data showed that in a marathon, for example, about a third of the participants release cardiac troponin, about a third elevate their BNP levels that we use to measure heart failure. And if you do sound wave tests, echocardiograms of their heart, about a third of them get some dysfunction, particularly of the right ventricle and the ventricular septum. Now, this all usually recovers over the next week or so, but certainly suggesting that there's some bad things that are happening during very extreme levels of exercise. And this is a paper that we just published a year or so ago in the Mayo Clinic Proceedings, again from the Copenhagen study, study of a very large number, 8,700 from Copenhagen, followed for 25 years. We showed in this paper that they measured sports activities and showed that doing sports activities, all the sports activities were counted, but you certainly got a mortality benefit. But the sweet spot seemed like it was somewhere in the 2.5 to 4.5 hours per week range. And they actually showed in this paper that if they did over 10 hours per week, they appeared to lose the benefit with a higher mortality compared to those doing less physical activity. So again, as Hippocrates said centuries ago, all things in moderation, we give every individual the right amount of nourishment and exercise, not too little, but also not too much. We may have found the safest way to health. Now, we have new physical activity guidelines for Americans. Basically, these are saying that the 2018 Federal Activity Guidance suggests 150 to 300 minutes per week of moderate physical activity, of 75 minutes per week of vigorous physical activity. All movement counts. In previous guidelines, they said you had to do 10 minutes in one interval to be able to count it, but now every minute of physical activity counts. Adults should do also 2 more sessions per week of resistance training or weight training. Older adults over age 80 should also do balance training, which might be even more important for the elderly than the aerobic training. Kids should be active throughout the day, and ages 6 to 17 should do at least 60 minutes per day of moderate to vigorous physical activity. Now, we're still in the COVID era. At least I think the main part of COVID may be over, but this is a paper that showed that fitness affected COVID as well, that those who were more fit before they got COVID had way less hospitalizations with COVID, and showed that for every 1 med high exercise capacity, the hospitalization for COVID was 15% lower, and actually correcting for other factors, it was still 13% lower. I wrote the editorial on this paper in the Mayo Clinic Proceedings, making the case, again, that this might really apply to the African-American population who had such a high mortality, at least early in COVID. And this is probably going to be the case in future pandemics as well. In California, Bob Hallis from Kaiser did a study of 50,000 adult patients, and in Kaiser they get physical activity on all their participants. I don't know if y'all seen Kaiser patients or not, but they have physical activity. Do they meet their guidelines? And showed in this paper that those who met the physical activity requirements, who later got COVID, had much lower rate of hospitalization, ICU admission, and mortality and mechanical ventilation. So we've been really pushing improvement in global health for pandemic protection and multifactorial. We published this, it's been cited almost 1,000 times, that right when COVID was hitting, we basically had two pandemics colliding with each other, the physical inactivity pandemic and now COVID, that really is, I think, going to put a toll on our society for many years to come, because with COVID, people dropped their physical activity and gained weight, and this is probably important for immunity. It's very important for our older population, who I think and our kids that were really affected by COVID. We need to do a much better job of promoting physical activity throughout the healthcare system, and we all should be doing this with every visit, with every patient. So in conclusion, the 2018 Federal Activity Guidelines suggest 150 to 300 minutes per week of moderate physical activity, of 75 minutes per week of vigorous physical activity, plus 2 times a week of some resistance exercise. I think the recent evidence, though, suggests that the benefits of exercise occur even at levels lower than this, particularly our running data. With running, the maximal benefits occur at very low levels. I think in almost everyone, the maximal health benefits occur probably at 40 minutes and certainly under 60 minutes. I think the promotion of physical activity and exercise training is needed throughout the healthcare system, which can start with having exercise or fitness part of our assessment of every patient, and improving physical activity, exercise training, and fitness may particularly be needed in the COVID era and beyond. So I think this is something we deal with every day. The patient may not say exactly this, but this is kind of what they're implying. Give it to me straight, doc. How long do I have to ignore your advice? And everyone says the reason why they're not exercising is they don't have time. And so the answer is, what fits your busy schedule better? Exercise. And I used to put an hour, 30 minutes, and now I think you could put 10 minutes. But exercising for so many minutes per day, or being dead for 24 hours per day. Thank you very much. And again, Mohamed, thank you for having me.
I just want to thank Dr. Lavie again. Excellent talk, and it's always good to hear about the obesity paradox before lunch so we feel more comfortable eating. But before we do that, we'll have some questions.
And you probably think it helps your interventional practice too.
He's the reason why I stopped my running at 30 hours a week, just so everybody knows.
I wanted to ask about the depression associated with, is it because people that are depressed do less exercise, or is there another factor associated with that?
No, so, I mean, obviously depression is a multifactorial process. I mean, there's certainly brain stuff, there's, so what causes, like, for example, do they get depressed because they're physically inactive, or does the physical activity cause depression? I think there's probably some of both, but certainly we know that they're very associated. We know, for example, that obese people have higher depression scores than non-obese. So there are certainly many factors involved, but it seems like increasing physical activity is having a significant impact on reducing depression. And it's interesting that I think that in cardiovascular disease, we don't probably focus on psychological stress enough, but in the psychological fields, they don't stress physical activity. And probably we both need to be coming together to improve not only the psychological health of our population, but also cardiovascular health.
Thank you.
Without exercise testing our patients, do you have any simple or quick screening tools for fitness?
Well, so certainly there are now algorithms that have been published where you can actually plug in several things from the electronic medical record and get an estimated fitness. Now the problem is it's not perfect, but it gives you R values of like 0.7, 0.8. Obviously that means there's going to be an occasional patient that, and this is without exercise data, but looking at things like the heart rate, the BMI, a simple physical activity question. I think what Kaiser does is just does a 2-question test. Are you physically active, and how many days per week do you do 30 minutes of physical activity? And it's a 2-point question, and so that's a very simple test that they've published many papers out of their data bank from Bob Kalis that's showing that really impacts prognosis. And then I think they also get an electronic pop-up if those questions are asked by the screeners before they put it in the room, and if they not meeting their physical activity requirements, they get a pop-up saying, "Did you prescribe physical activity?" Another click for us in the office, but it's probably one that's more worth it than some of the clicks we do.
Role play with me, if you would. In a clinical visit, what is your most effective 15 or 30-second message you give to your patient?
I ask them, what are you doing for exercise? Are you physically active? And so they answer that. And then if they're not physically active, I say it really would be helpful for you to improve your physical activity, find something that you like. The easiest thing for most people to do is walk. I think you have bad knees, so you might find a better thing to do with an exercise bike or elliptical machine. The goal is to be doing about 150 minutes per week. That's about 30 minutes, 5 days per week. And that's a pretty short, it doesn't take too long of my day to do that.
Thank you. What do you think is the reason for super fit people doing worse than moderately fit? Is there any thought on that? Because obviously they have leaner heart.
So the problem is that for this, there's no way you can do randomized studies. So that most of this kind of information, you got to do it on cohorts. It's certainly possible that doing super high has some harms. But it's also possible that the person who's doing these super highs has got some differences to begin with. So maybe they're people that are not sleeping as well. Maybe they're more stressed out people, although exercise would be tending to help their stress. Maybe they're using substances more. So it's hard to know if is it just association or is it causal. Again, I don't try to work too hard to persuade the super exerciser to cut down. I don't think super exercising is the big problem in our society. It's the other end. It's physical inactivity. But I do think that the super exerciser is not doing it for health. The super exerciser is doing it for other reasons. Sport, stress release, they love it, the competition. People do a lot of things that aren't just for health. They jump off mountains and race boats and race cars. So not everything's about health. But so I think that for people who are doing the exercise for health, the dose could be a lot lower.
I was surprised to hear about the resistance training. How long does it need to be?
So typically resistance training would be 10 to 15 minutes. And actually we published a paper in MSSE, which is the leading it's medical science, sports and exercise journal. It's the leading physical activity journal in the United States about 3 years ago that showed that resistance exercise training added statistically to cardiorespiratory fitness in predicting cardiovascular and all-cause mortality. And we showed in that paper that, again, the guidelines are 2 to 3 times per week. We showed in that paper that those who were just doing 1 or 2 times per week seemed to get the maximum benefit from the resistance exercise. And so it's actually pretty easy to do that. I would say 10 or 15 minutes per week of doing light weights or doing hand grip type exercises. And you don't have to be in a gym. Obviously, if somebody's in a gym, they can do it. But having just some hand weights and supplement your aerobic exercise, which would, for most people, is going to be walking or a bicycle, elliptical machine, or jogging.
Okay. Does it
with
need
that.
to be split up? Say I do an hour of a resistance class.
Yeah, no, it doesn't have to be at the same time, for sure. And it can, and probably it could be 5 minutes twice. And I think that doing push-ups, doing pull-ups, doing core exercises would all count as resistance exercise. So you don't really need to even have equipment to do some of that. I think doing hand weights and hand grip stuff is probably the easiest stuff that most people could do at home.
Why, after 5 decades, were housewives doing less housework and using less calories because of automation, technology, better vacuum cleaners? I mean, you know.
So if you think about 5 decades ago, the work that the typical woman had to do to keep the house up, it took a lot of physical activity because they didn't have all the automation. So automation has been a great thing for our society, but that's been a negative of it. You know, so you actually don't. So now when you do physical, you can get by without doing hardly any physical activity. Before you couldn't really get by. You almost had to do some physical activity to get through the day and to keep your house. You know, you had to, washing the clothes was a lot harder 5 decades ago than it is today.
I'm just going to ask one more question in terms of technology and exercise. Is there any tools that you use to track your patients that say, hey, I do exercise 30 minutes a day, I do it 5 times a week, anything like that?
Yes, so certainly one simple thing is questions and questionnaire. But if a good tracking device would be the steps. You know, and that's not perfect because not all steps are equal, because having some steps that are faster would be helpful, and there's even some devices that can, like a accelerometer that would give you the steps and some of the speed of the steps. But I think the simple thing would be the steps. And again, the goal being to get most people to get closer to 10,000 steps, and honestly, probably 15,000 is better than 10,000. But you know, right now, probably many people are getting 3 or 4, 5,000 steps per day, so we're not even close to getting to the 10,000 for most people.